The topic here is going to be diabetic retinopathy, and this is a very important um, topic in ophthalmology in your clinical practice if you're working an outpatient clinic or even if you're working with older adults as a hospitalist. The reason is because so many people have diabetes. 10% of Americans have diabetes, and I think that's a conservative estimate because a lot of people have diabetes and don't know. Furthermore, that number can only be expected to increase as our population gets fatter. People are going to be more and more likely to develop diabetes as they get older. So diabetic retinopathy is not fully understood as far as its pathophysiology goes. However, what we do know is that it's a pathologic breakdown of retinal small vasculature, and it's due to persistent hyperglycemia. And this damages the pericytes, which are responsible for maintaining the blood-retinal barrier, and it also damages the basement membrane of the vessels. And so because of this, you damage and ultimately destroy the vessels, but not before causing fluid to move out of the vessels, proteins, lipids to move out of the vessels. So this is a breakdown of the retinal vasculature, and it's primarily encountered in patients with poorly controlled diabetes mellitus. But some people may have well-controlled diabetes and still develop retinopathy. But having controlled diabetes and making sure it is controlled will do you a lot of good in reducing your risk of progressing towards diabetic retinopathy. Okay, so this is the leading cause of new onset blindness in adults aged 20 to 65 years. It affects up to 80% of patients who have had diabetes for 10 years or more. Now, a lot of people have diabetic retinopathy and they don't know it and they don't have symptoms, and if they may not ever develop symptoms from it. So that 80% number is staggering, but it's not necessarily reflective of how many people really have problems from diabetic retinopathy, but it is reflective of how many people could develop problems from diabetic retinopathy. It all comes down to how well you're controlling your diabetes most of the time. So remember that the leading cause of new onset blindness in the elderly, people 65 or older, would be macular degeneration. So in patients with type 2 diabetes, when they're diagnosed, 40% of patients will have some retinal changes, some vascular changes, some change on an ophthalmoscopic exam that's consistent with diabetic retinopathy, even though they don't have symptoms. 20% of patients who are newly diagnosed with type 2 diabetes mellitus actually do present with visual changes as their presenting symptom or one of their presenting symptoms of their diabetes. That said, all patients with a new diagnosis of type 2 diabetes mellitus should be referred to ophthalmology for a baseline evaluation. In patients with type 1 diabetes, because these are usually children, retinopathy will not present for at least 3 years after diagnosis, and typically these patients don't need to start getting observed by an ophthalmologist until they're in puberty. The best management for diabetic retinopathy is primary prevention, as I've alluded to, so controlling blood glucose level through a healthy diet, exercise, and anti-hyperglycemic medications and insulin if necessary. So we classify diabetic retinopathy into non-proliferative and proliferative. And proliferative just means that you're growing abnormal new vessels. So non-proliferative diabetic retinopathy would actually make up the majority because the majority of people who have diabetic retinopathy actually don't know it. And that would be the people who have background retinopathy. So this is where you show signs of diabetic retinopathy on ophthalmoscopic exam, notably microaneurysms, small hemorrhages, which can be dot blot hemorrhages or flame hemorrhages, and hard exudates, which actually comes from vessels that have been destructed. So these patients will have mild changes on ophthalmoscopy, but they don't have any symptoms and they don't have any changes in vision, even though they have these changes on ophthalmoscopy. This doesn't require any immediate treatment, just the primary prevention of keeping the glucose level normal, making sure that they exercise, all those things you can do to prevent progression into proliferative diabetic retinopathy. Now, on the other hand, you can have diabetic maculopathy, and that's different from diabetic retinopathy. Diabetic maculopathy is a manifestation of diabetic retinopathy, and this is where you have edema and exudates or hemorrhages that involve the macula. So, whereas with background retinopathy, you had these changes on other parts of the retina, if these changes involve the macula, typically it's going to cause symptoms. And those symptoms are the same symptoms that you would have with any kind of macular problem. Blurring, decreased acuity, darkening, those scotomas that you see in your central vision, and visual distortion. So this would be a symptomatic form of non-proliferative diabetic retinopathy. This is diabetic maculopathy. Apart from using the ophthalmoscope, you can also do optical coherence tomography, and this will better visualize where the problem is and its severity. And maculopathy is the #1 cause of blindness in patients with diabetic retinopathy. So you can go blind with diabetic retinopathy, and you don't have to have the worst form, which is proliferative diabetic retinopathy. All you need is to have maculopathy, and if it doesn't get treated soon enough, and even if it does sometimes, you can have a permanent decline in your vision or total blindness. Now, the worst form is proliferative diabetic retinopathy, and this is the most advanced stage of diabetic retinopathy, and of course it's associated with a poorer outcome. It's characterized by neovascularization, which tends to be pretty obvious from the optic disc or major vessels, and because those vessels are fragile, you can get vitreous hemorrhaging, and you can also get tractional retinal detachment due to any of the fibrosed vessels that have been diseased and fibrosed, and that can be a tractional spot for retinal detachment. I'll show you a picture towards the end of the lecture. Vascular proliferation can also involve the anterior structures of the eye, notably the iris and the angle, and that can result in glaucoma because the vessels will block the angle, and that will raise the intraocular pressure, and that leads to something called neovascular glaucoma. That is a complication of diabetic retinopathy, but we're not going to talk about it here because that's a topic for another subject when we talk about glaucoma. Okay, so this, for the most part, is a normal retina. So you might see here are a few changes associated with diabetic retinopathy, but certainly nothing that would cause symptoms. So you might have a dot blot hemorrhage down here at about 6 o'clock. And also at about 6 o'clock, 5 o'clock, you've got some hard exudates. Okay, and just remember that the hard exudates are just kind of scar formation, but they're due to breakdown of the blood-retinal barrier, and what they are proteins and lipids, as well as proteins from the vessels. So they're just dead vessel. Okay, so you might see some here, and then perhaps some up here. Now this is a little bit more obvious. Here you've got your dot blot hemorrhages. Here you have some dot blot hemorrhages all around here. This looks like it might be a burst thrombosed vessel. And here's some flame hemorrhages, and then you have your exudates, hard exudates here, these bright spots. Here's some very obvious hard exudates, not quite on the macula though. The macula is right here. This is zoomed in a little bit more than the other ones. The macula is right here, so the macula is not involved. You've got some bleeding here and hard exudates, but nothing that's involving the macula. You don't have any neovascularization. Okay, so this would be an advanced feature of non-proliferative diabetic retinopathy. So this is called a venous loop or a venous bead. And when you see these, this is rather ominous, and it says essentially that the patient is at risk for developing a significant risk for going on into the neovascular form, the proliferative diabetic retinopathy. I'll show you some more pictures of these when we talk about proliferative. So again, here you see tortuosity. That's another bad sign. They're abnormal appearing vessels. Okay. So diabetic maculopathy is disease that affects the macula. So this often occurs with non-proliferative diabetic retinopathy, but it can also occur in the setting of proliferative diabetic retinopathy. So unlike background diabetic retinopathy, diabetic maculopathy is symptomatic, and it can be considered a more advanced form of non-proliferative diabetic retinopathy, but patients with diabetic maculopathy do not necessarily progress into proliferative diabetic retinopathy. The whole question is, what part of the retina is affected? You have one little part of your retina called the macula, and it's very important. And as long as the macula is not affected, for the most part, you're not going to have any symptoms. But once that macula is affected, you're going to start to show symptoms. And those symptoms include loss of visual acuity, scotoma-like black spots in the central vision, blurred vision, image distortion, especially relative to the other eye. What does this sound like? This sounds like macular degeneration. And all that means is that the macula is not functioning properly. So when you look into the patient's eyes, you will see signs consistent with diabetic retinopathy, especially since this is a patient that probably already has diabetes, or labs consistent with diabetes, and you'll see that the macula is affected. For diagnosis, an ophthalmoscopic exam is the first test, and that will show abnormalities. It'll show the hard exudates and the hemorrhages in the area of the macula. Then optical coherence tomography, as I mentioned, is more accurate, and that can show you the macular edema that's consistent with diabetic maculopathy. So here's diabetic maculopathy. This is the macula right here, and you see hard exudates on the macula. So the macula is affected. Unlike the previous pictures I've been showing you, the macula was not affected. And here's some more. And this is the optical coherence tomography. This is the macula that you're looking at right here. And this should be flat up against the layer deep to it. But you've got fluid collecting up beneath the macula, and that's what's causing the symptoms. This is macular edema. And pretty much always macular edema accompanies diabetic maculopathy, but it can be difficult to see macular edema just with your ophthalmoscope, unless you're a master ophthalmologist. So this is a good way to confirm your diagnosis. If you have a picture like this one that doesn't necessarily show a whole lot of abnormalities on the macula. Most ophthalmologists will do this test in patients that they suspect maculopathy. So the way that this is treated is by laser photocoagulation. Sometimes they use intravitreal VEGF inhibitors, or they can use vitrectomy if there's consistent problems with bleeding. But diabetic maculopathy is primarily treated with laser photocoagulation. And as usual, primary prevention will continue to be important in these patients. Proliferative diabetic retinopathy is the most advanced stage of diabetic retinopathy. In this case, native vessels have endured damage to the point where new vessels are forming. And proliferative diabetic retinopathy is characterized by neovascularization, and that can occur anywhere from the optic disc to the major vessels and beyond. Hemorrhaging is very common, microaneurysms, dot blot hemorrhages, And vitreous hemorrhage can be present as well, or it may also be the presenting symptom in some cases. With continued vascular proliferation, new vessels can progress to the anterior structures and they can block the angle of the eye. That can lead to glaucoma. Dead vascular tissue can fibrose and can act as a source of traction, and that can lead to tractional retinal detachment. The symptoms of proliferative diabetic retinopathy can be blurred vision, and that can be either from vitreous hemorrhage or macular edema. Floaters, and that can be from if there's any kind of vitreous material or any blood or material in the vitreous, that can cause floaters. Difficulty with nighttime vision. Symptoms of complications can be present. So if you have retinal detachment, you can have photopsia, floaters, visual field deficits. If you've got neovascular glaucoma, then there can be pain, photophobia, and you can see neovascularization of the iris, and then you can also see conjunctival injection with that. Like I said, we're not going to talk about these complications. We talked about retinal detachment. We'll talk about glaucoma pretty soon, where I'll address neovascular glaucoma. But these are some of the complications that can come up, and with proliferative diabetic retinopathy, you can have symptoms of complications as presentation. So the way to diagnosis, of course, is through ophthalmoscopic examination, and typically patients with diabetic retinopathy, we're doing an ophthalmoscopic examination on them every year, or the ophthalmologist is, and so we're charting their progression. And that ophthalmoscopic examination is necessary to establish the diagnosis, along with other tests like visual field tests and acuity exams. Another thing that can be done is ocular tonometry. If they show signs of glaucoma, that measures the intraocular pressure if glaucoma is a concern. The treatment for proliferative diabetic retinopathy is panretinal photocoagulation. And this tends to be the first line treatment. However, other things can be done, especially this new treatment. It came out within the last 10-15 years at most, and that's intravitreal VEGF inhibitors. And what you're doing is you're injecting VEGF, which is a product that inhibits vascular epithelial growth factor, and by doing that, you will inhibit the growth of new vessels. And so this is an injection that's put into the vitreous. There's another, I'm trying to remember, I think it's triamcinolone, which is a steroid. That can also be used, but usually the intravitreal VEGF inhibitors are used if you're using medication. But panretinal photocoagulation, I would say, would be your answer on the USMLE if you get a question like this. So this is proliferative diabetic retinopathy. You can see here you've got what look like those loops here, and then here coming out from that you've got neovascularization. And this is pretty close to the optic disc. And of course you've got bleeds, dot blot hemorrhages. This is severe proliferation. Here's another one. So you can see there's a locus of proliferation, neovascularization here, some neovascularization coming out of the optic disc. But the macula is spared here. So here's proliferative diabetic retinopathy with a vitreous hemorrhage. So this is a patient that may present with a gradual blurring of vision because they're looking through blood. Here's a fibrous band. This fibrous band is just dead tissue that can show up with diabetic retinopathy. And the problem with these fibrous bands is as you're turning your eyes, these can be points, traction points, where you can get retinal detachment. And retinal detachment is a whole other animal that's treated in a totally different way, but it's very problematic when you have diabetic retinopathy because the retina is already fragile. So you don't want this. This is diabetic retinopathy, but this isn't a patient who has had photocoagulation performed, and that's what these little white spots are. They're just scars from the laser. Notice that they, of course, went around the macula, because if you photocoagulated the macula, well, then you'd have no vision. So it went around the macula here. That's why this area is not done. So further management, remember that patients with diabetes mellitus are at increased risk for other ocular problems besides just diabetic retinopathy. There's also an increased risk for cataract formation, as well as thrombosis to the retinal artery. All patients with diabetes should have blood pressure and lipids monitored. Remember that blood pressure increases your risk of clots and atherosclerosis. And atherosclerosis and clots will increase your risk of thrombosis to the retinal artery. And they should also have their lipids monitored for that reason too. And of course, any adult patient in general should have those things measured, but it takes on more importance in the patient with diabetes. A hemoglobin A1C is the best way to monitor a patient's long-term compliance, long-term progress with their diabetic regimen. And we prefer to have these patients between 6 and 7%. Smoking reduces retinal oxygenation and may upregulate VEGF, so that would accelerate progression to or of the proliferative disease if they already have it. So stopping smoking is always a good idea, but particularly in patients who have diabetic retinopathy, we want them to stop smoking so they don't start making more VEGF and putting themselves into the proliferative disease. Also, since we're talking about diabetic patients already, beware of prescribing the thiazolidine diones, TZDs. Why do we want to avoid these? Because they are associated with an increased risk of macular disease. So we would prefer to have the patient on a different kind of anti-hyperglycemic if we can. The thiazolidine diones are medications like rosiglitazone or Avandia or pioglitazone, which is, I think, Actos. So remember that when you've got your patients with diabetic retinopathy. When do you refer to ophthalmology? Well, of course, any patient that needs a procedure done needs to be referred to ophthalmology. All new type 2 diabetics will be needed to be referred to ophthalmology for their initial examination, and then they'll be seen every year after that. All type 1 diabetic patients should be referred roughly 3 to 5 years after onset or around puberty. It depends on the age. So if they're adult patients, you could refer them 3 years after that. If they're little kids, like 3-year-olds, then around when they hit puberty, then they should go see an ophthalmologist for a baseline exam. And then, of course, all diabetics who have an acute change in vision, even if you don't see anything with the ophthalmoscope, a handheld ophthalmoscope is not a great way to make some of these more complex ophthalmologic diagnoses. So any diabetic with an acute change in vision should be sent straight off to ophthalmology. And of course, any diabetic with a sudden drop in acuity, we're concerned about the macula, those patients should be sent off to ophthalmology urgently as well. If you have any questions, please feel free to leave a comment below.